Is the name reflected as Vijay Shah or VT Shah?
Vitisha, sir, whatever you have sent, I have just put that.
Yeah.
I will tell as a Vijay Shah. Don't worry, sir.
No, VT Shah.
Vitisha, I will tell. Okay, fine. That all I will tell. Not an issue.
No, but how do I change the view, the name? I think that's the name coming on my screen for my.
Uh, Sir, your name is coming as Vijay Shah.
Yeah, that's what I'm saying. So I have to change that. Tech team, how do I change this?
Tech team will change that one, sir.
Ask them to change to Dr. VT Shah.
Tech team, please change to Dr. Vitisha. Vijay Shah to Dr. Vitisha.
So come on, let us start now. We are getting late. Otherwise, that's
Sir,
not
we are not on live till.
attendees will
Done.
run away then.
Sir, change it. Change. Yes, sir. Sir, VT Shah is right, sir.
Yeah.
Okay.
Yes, sir. It's done. It's done. It's done, sir. Sir, we are live right now.
Okay. Hello and good evening. Welcome to the expert crosstalk on Empagliflozin, multi-benefits and multi-indications by multi-mechanisms. As we already knew that ESC 2020 was memorable with the
A
path-breaking...
bit louder. We can't hear you. And a bit slow.
As we already knew that ESC 2020 was memorable with the path-breaking clinical data presented from multiple global trials. This program is designed with the objective of dialogue between two different specialties, that is cardiology and endocrinology, which would bring upon two different ways to address the complexities of the clinical cases in heart failure. So according to Emperor HF trial, does SGLT2 inhibitor can be considered as an important drug for HFrEF? For this, let me introduce today's speakers. Yeah. Today's speakers are Dr. Vijay Shah and Dr. Pradeep Talwalkar, and I'm a moderator, Dr. Shovik. Dr. Pradeep is a consultant diabetologist at SL Raja Hospital in Mumbai. He is also a postgraduate teacher in diabetology, College of Physicians and Surgeons in Mumbai, and honorary diabetologist at Sushrusha Hospital, SR Mehta Hospital, Dhanvantari Hospital, and Global Hospital in Mumbai. He is also a principal investigator of various clinical trials and has several national and international publications in his credit. I welcome Dr. Pradeep in this expert web talk. Our next speaker is Dr. Vitisha. Dr. Vitisha is a senior consultant intervention cardiologist in Mumbai and trained in Germany in intervention cardiology with more than 30 years of clinical practice. He is also ex-president of NSPHERE and also co-founder of CCA International. And he has got several publications in circulation and different heart journals, and also specialized in IVUS, OCT, FFR guided complex interventions, CTO and LM bifurcations, primary angioplasties. And also a senior consultant intervention cardiologist in Global Hospital, Bukhara Hospital, and several renowned hospitals like Raheja Fortis Hospital and Prince Ali Khan Hospital in Mumbai. I welcome Dr. Vitisha in this expert web talk, and I'm handing the session to Dr. Vitisha to start with the presentation. Thank you.
Yeah. So good evening, friends. So today we are going to talk on this SGLT2 inhibitors, empagliflozin in particular. Now, Dr. PG Talwalkar was supposed to initiate this talk and give you an overview of empagliflozin in the treatment. Yeah, Dr. Talwalkar is there. Good evening, sir. Dr. Talwalkar?
Please unmute yourself, Dr. Pradeep. Good evening. We are finished with the introduction. Can you please start?
Can you please start your presentation, sir?
You are supposed to talk first. I don't mind talking now, but I was waiting for you.
No, you please talk, sir, because I told them it's a diabetes molecule and cardiologist is secondary to the diabetologist. So,
I don't think so. I
and
will
my
start.
my slides don't contain any of the anti-diabetic
Sir, Dr.
actions of
Pradeep,
this drug or anything else. It's just
sir,
pure cardiology.
uh,
So,
Okay, I
sir,
will start. No problem.
yeah, thank you very much. So I thought it would be better if you can start. And it would be a pleasure to share the same platform with Dr. Pradeep Talwalkar, who has been a colleague for many years. And we learned a lot of diabetes from him, especially in these last few years when we have so many molecules in common. So, Dr. Pradeep Talwalkar, please take over. And
Okay,
let
I think I will let the host present the slides for me, and then I will talk from here. Go ahead. Show me my first slide, please. Thank you,
stating,
Dr. VT.
Yeah,
I
yeah.
am not
Thanks.
associated.
It's a pleasure to be with you so that
Yeah,
I learn more of diabetes, because diabetes has changed over a period of many years now, especially from the days when we were in college.
stating
we have
condition.
taken a lot of lectures together. This is one more occasion for us, both of us, to join as faculty,
Correct.
and I like it very much. Let's
Uh,
start the program proper.
Sir,
Let me
Yeah.
we are
have the
live,
first
sir.
slide.
Tech team, please share the slides for Dr. Pradeep. Ravi,
Yes, sir.
please share the slides of Dr. Pradeep.
सर मुझे स्लाइड्स नहीं मिला अभी तक एक्चुअली.
Dr. Pradeep, you have the slides?
Let me see whether I can.
No,
Yeah,
you can share the screen actually.
yeah, I'm sharing the screen. Can you see my slides now?
Yes, 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 yes.
Yes, yes.
Now,
Fantastic. Very good.
now put it a full screen mode, sir.
Yes.
Yeah. Put
Okay.
it. Yeah, fine. That's fine. You can start. Thank you.
Okay. So the subject today is empagliflozin in particular and SGLT2 inhibitors in general, and we will talk about their mechanism of action. Particularly, we will concentrate on diabetology, and Dr. V.T. Shah will then concentrate on cardiology. As all of you know, introduction of SGLT2 inhibitors in diabetes practice is a milestone. It has changed the way we look at anti-diabetic therapy, and it has changed the way how we treat the diabetic patients. Previously, we used to be glucocentric. We used to concentrate on drugs which were very efficient in controlling blood glucose. No matter whether they increased weight, no matter whether they produced hypoglycemia, no matter whether they led to increased prevalence of myocardial infarction and atherosclerotic cardiovascular disease, we went after glycemic control. But with the availability of new drugs like SGLT2 inhibitors and GLP-1 analogs, we are looking at a drug which will not only control blood glucose, but which will prevent atherosclerotic cardiovascular disease, which will prevent death from atherosclerotic cardiovascular disease, hospitalization for heart failure. It will protect the kidneys, it will reduce the blood pressure, it will reduce the weight. And we are looking at that kind of all-inclusive drug. And one of the best drugs for that is empagliflozin. Multiple indications have come in, multiple mechanisms of action are there. Let's go ahead with a drug which has made a paradigm shift in the management of diabetes. As I said, I would look into diabetes perspective. There are 4 or 5 SGLT2 inhibitors. DAPA was the first one to complete its various research project and start publications. Then came Remo, but Remo went into a background. It almost became an orphan drug because no multinational was taking it. It went into a cold storage and it has been picked up by Indian company. Then Cana, then EMPA, and we will look into how they act, what are the similarities, what are the differences, what are the cardiovascular outcome trials, what are the renal protective trials, and so on and so forth. Basic mechanism of action of SGLT2 inhibitors, including empagliflozin. It makes kidneys excrete glucose by preventing its reabsorption. And this is done at the proximal convoluted tubules where SGLT inhibitors are there, SGLT2 receptors are there. And the normal action of SGLT2 receptor is 95% of the glucose and sodium which is filtered by the glomeruli is reabsorbed from the tubules into the circulation by SGLT2. Most of the action, more than 90% of this action is done by SGLT2 and about 10% by SGLT1. So if you block these SGLT2 enzymes which are present in renal tubules, you block the reabsorption of filtered glucose by the glomerular. If you block the reabsorption of filtered glucose, that much glucose, about large amount of glucose is lost in the urine. That much by that much the blood sugar comes down, and you lose the energy in the form of glucose. That by that much the weight comes down, and because of the excretion of extra sodium, the blood pressure comes down. And since this action is totally independent of insulin access, it doesn't cause hypoglycemia. Remember, there are only two groups of drugs which are totally independent of insulin. Metformin is not independent of insulin. Pioglitazone is not independent of insulin, even though it doesn't make pancreas to secrete more insulin. For it to produce its results indirectly, there has to be insulin in the body. The only major group of drugs which act without insulin are SGLT2 inhibitors. Others, of course, are drugs like acarbose, but they are the minor players in the management of diabetes. So this is done through the blockage of SGLT2 action at the proximal convoluted tubules. All the SGLT2 inhibitors have similar mechanisms of action with slight differences from here and there. They are usually given once a day, except Remo, which is given twice a day, because they have a biological half-life, which is about 12 hours. Their plasma peak is about 1.5 to 2 hours. They are metabolized in the liver, and the metabolites do not have any anti-diabetic action, so there is no chance of hypoglycemia. Eliminated within 12 hours, once a day action, and glucose excretion varies from 70 to 80 grams of day. So no matter what is the type of diabetes, what is the duration of diabetes, what is the status of beta cells in pancreas, your blood glucose has to come down, because at least 80 grams of glucose will be excreted from the body. And by that much amount, the blood glucose has to come down. They reduce the HbA1c by about 0.8 to 1% when they are tried in mildly diabetic patients in various phase 3 trials. But if you do it in clinical practice where HbA1c is very high, the HbA1c reduction is much more. Now, this is the empagliflozin pooled phase 3 clinical trials. Monotherapy with empagliflozin on the top of metformin, empagliflozin on the top of sulfonylureas, on the top of pio, on the top of sulfonylureas plus metformin, on the top of insulin, and in renally impaired patient. 10 milligrams, 25 milligrams versus placebo. Across the board, across all the clinical trials, empagliflozin was far superior to placebo in ability to reduce HbA1c across all the phase 3 trials in different indications, as seen in this bar chart. Of course, empagliflozin 25 milligram was marginally superior to empagliflozin 10 milligrams. Empagliflozin pooled phase 3 placebo-corrected change from baseline in body weight. Type 2 diabetes is associated with increase in body weight. Most of the patients are overweight, if not overweight by BMI standards. Most of the Indian patients are overweight by waistline criteria and central obesity. So one of the main aim of reducing of treating type 2 diabetes patients besides HbA1c reduction is weight reduction. And here both 10 milligrams and 25 milligrams of empagliflozin across the different types of trial and the pool data itself, monotherapy, combination with different permutations and combinations. When you use empagliflozin, it leads to a significant reduction of body weight as compared to placebo across all the trials in different countries. And what is more important is 66% of this body weight, 2/3 reduction of body weight is reduction of visceral fat. There was a misconception when these drugs came into the market that are they reducing muscle mass? It is dangerous to get a muscle mass reduced. Are they increasing the edema? All these things are wrong. They are reducing weight by reducing visceral fat, which is most wanted thing across all the clinical trials. What else empagliflozin showed besides weight reduction, besides significant reduction is HbA1c, is a change in systolic blood pressure from baseline, and there was a significant reduction in systolic blood pressure from baseline in all the phase 3 empagliflozin trials across all indications, such as whether it was monotherapy on the top of metformin, on the top of pioglitazone, on the top of metformin plus sulfonylurea, and on the top of insulin. About 2.5 to 3.5 to 4 millimeters of HD reduction of systolic blood pressure across all the trials. And this systolic blood pressure was not only reduced at one point or a couple of points during the 24 hours cycle, but across 24 hours cycle, as you would see in this trial. In a 12-week trial, these are the top graph is a baseline where and the lower graph is at the end of 12 hours. Significant reduction of systolic blood pressure, nighttime reduction, peak time reduction, daytime reduction across all the day. It also reduces the diastolic blood pressure, which is slightly lesser than significance level, but still considerable amount of diastolic blood pressure reduction. As you see, gray line is placebo, blue line is 10 milligrams of empagliflozin, and red line is 25 milligrams of empagliflozin. Again, throughout the 24 hours, morning peaks are also avoided, nighttime dip is maintained, smooth reduction of diastolic blood pressure, though slightly less than what was required for a significant level. Empagliflozin pooled phase 3 data. What happens to lipids? This is interesting to know. Good improvement in HDL cholesterol, some increase in LDL cholesterol, but if you go into details, it is not the increase in it is increase in relatively less dangerous LDL cholesterol, large LDL molecules, and not small dense LDL particles. Reduction in triglyceride, increase in HDL cholesterol, and reduction and some increase in LDL cholesterol, but overall lipid profile is not detrimental. Overall lipid profile is beneficial because increase in HDL cholesterol, reduction in triglyceride, and whatever little increase in LDL cholesterol was there was because of large dense particle. And there is a proof of the pudding is in the eating. Similarly, all the cardiovascular outcome trials are so much beneficial effects they have produced. So obviously, it cannot be detrimental to LDL cholesterol. Now, next, this is across the board, the effects on body weight, effect on HbA1c, effect on systolic blood pressure of all the various different trials on SGLT2 inhibitors, different countries, different dosages, but the findings are same. Now, what are the detrimental effects? The urinary tract infection is more common in patients on SGLT2 inhibitors as compared to patients on other group of anti-diabetic medications. But most of these increase in urinary tract infections are lower urinary tract infections, simple urinary tract infections which are controlled easily by the oral antibiotics. Mind you, diabetic patients not on SGLT2 inhibitors also have increased urinary tract infection as compared to non-diabetic persons, but those on empagliflozin and along other SGLT2 inhibitors, definitely more, but not troublesome because acute pyelonephritis is very rare. Even chronic pyelonephritis is rare. Fatal cases are almost unheard of. Most of them are lower urinary tract infection, easily treatable by oral antibiotic. What about fungal infection, genital fungal infection? They are little even more common with gliflozins, including empagliflozin, as compared to placebo or other anti-diabetic drugs not belonging to SGLT2 inhibitors. But there again, even a diabetic patient treated by any non-SGLT2 inhibitors also has a slightly higher chances of getting these. So comparatively, yes, they are there. their incidence and prevalence can be reduced by improving the hygiene of the patients, warning them about the possibility of balanitis in male and vulvitis in females, giving them the prescriptions about the antifungal local topical agents, in addition to giving them advice about better hygiene, and asking them to start using these local antifungal agents immediately after the symptoms, which expected symptoms, to minimize the prevalence and trouble to the patient. The other side effects are volume depletion, but if you are careful, if you reduce the dose of diuretics, if you control the patient's uh, fall of BP after standing, manage that thing, manage his dehydration, and then start these gliflozins, including empagliflozins, these problems can be reduced. Fracture problem is only with canagliflozin, it is not with empagliflozin. Now we come to the cardiovascular outcome trial, empagliflozin and cardiovascular outcomes in patients with type 2 diabetes mellitus. I told you at the start, the paradigm shift has occurred in the way we manage type 2 diabetes. Why has this paradigm shift has occurred? One of the main reasons is this EMPA-REG trial. What was the genesis of EMPA-REG trial? Why was EMPA-REG trial done? The simple indication for EMPA-REG trial was this was made mandatory because in a few years before empagliflozin was launched, rosiglitazone was associated with increased myocardial infarction and increased cardiovascular death. So United States of America took a decision that further to that, that means further down the line after 2008, any new anti-diabetic drug will have to prove its safety to the heart by doing a specifically designed cardiovascular trial by including elderly patients, patients having cardiovascular disease, patients having renal disease in the inclusion criteria. So don't do trials in young patients who don't have any problems, but do trials in elderly patients already with cardiovascular disease, prove that it is safe, and then you launch the product. So in order to prove that it is safe, they designed a trial which was known as EMPA-REG trial. And what happened was, they not only proved that it was safe, but they proved that it was cardioprotective. I will show you what are the findings. Not only safe, but cardioprotective. And then the entire guidelines were changed. The Cardiology Association changed the guidelines, the Diabetes Association changed the guidelines. Universally, the guidelines to treat diabetes were changed when EMPA-REG and similar trials came out and gave their findings. Let's go into these findings. Cardiovascular outcomes, with the primary cardiovascular outcome in EMPA-REG trial was 3-point MACE, so a combination of cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. And there was significant 14% relative risk reduction for composing 3-point MACE endpoint. Now let's look at cardiovascular death. Very impressive 38% relative risk reduction of sudden cardiovascular death in those patients on empagliflozin as compared to placebo. Both the groups on top of aspirin, both the groups on top of statins with good treatment for diabetes, empagliflozin had these benefits. So 38% relative risk reduction from cardiovascular death, 32% relative risk reduction from any death due to any cause, and 35% relative risk reduction from hospitalization for heart failure. Both the groups were treated very aggressively for diabetes. On the top, one group got empagliflozin, other group got placebo, and both the groups were very effectively treated for lipid problems, blood pressure problems, heart failure problems. But this was the difference. They went on to prove the safety, and they proved the protective effect against cardiovascular death, against all-cause mortality, and against hospitalization of heart failure. These were the primary endpoints, but there were secondary endpoints in which the renal safety was studied. Here again, in order to, they went ahead to prove renal safety, but what they proved, incident and worsening of nephropathy was significantly less. Progression to macroalbuminuria was significantly less, and composite renal outcomes was also better in those patients who were on empagliflozin in EMPA-REG trial as compared to placebo. So cardioprotective effect, renoprotective effect, weight reduction, systolic blood pressure reduction, and prevention of hypoglycemia. These were the findings. So these studies have helped the mankind immensely. Diabetologists have learned much more about diabetes because of these studies. Cardiologists have learned much more about the diabetic heart disease, particularly heart failure, and everybody has become wiser, and patients have benefited immensely because of these cardiovascular outcome studies. Initially, it was thought, is it required? Is the American government going too much ahead? Are they wasting money? Will anybody be interested in introducing new anti-diabetic drugs with so many trials required? But the picture has changed, and it has resulted into shift how we treat the diabetic patients. In the EMPA-REG outcome trial showed that cardiovascular benefits, and what is the difference between the cardiovascular benefits provided by EMPA-REG and cardiovascular benefits provided by those drugs like statin, which work slowly, because statin works through reduction of atherosclerosis. Empagliflozin and other gliflozins work through reduction of various other factors like diuretic effect, preload reduction, afterload reduction, control of blood pressure, control of weight, prevention of hypoglycemia. And these effects come much, much earlier as compared to the protective effect offered by the statins. Statins require months and years to show the difference between those on statins versus those on placebos. But with empagliflozins, the results came very early. Say, for example, reduction in risk with empagliflozin versus placebo reached significant at day 17 for hospitalization for heart failure. That means as early as within less than 3 weeks, patients on empagliflozin had less chances for hospitalization for heart failure as compared to those who were not on empagliflozin, those who were on placebos. And similarly, benefits for cardiovascular death also came within 59 days. Your patient on empagliflozin will have a significant chances of death reduction if he is a typical type 2 diabetic elderly patient with a very high risk or existing cardiovascular disease. The death will start reducing within 59 days. So very early protection is offered by empagliflozin as compared to protection offered by drugs such as statin, drugs such as blood pressure reducing agents, drugs such as antiplatelet agents, etc. As you know, the large number of cardiovascular outcome studies have been done on DPP-4 inhibitors, on SGLT2 inhibitors, and on GLP-1 analogs. I will tell you the rough points. DPP-4 inhibitors have found to be safe on heart, but not protective to the heart. GLP-1 analogs, depending upon what is their structure, those which have a natural structure are found to be protective to the heart like SGLT2 inhibitors. But those who are on extended platform, the synthetic GLP-1 analogs are only cardio safe, not protective. Among the SGLT2 inhibitors, empagliflozin has a very, very significant protective effect or relative risk reduction from cardiovascular death, whereas dapagliflozin and canagliflozin are equally good, or 3-point MACE. They are equally good for prevention of heart failure hospitalization, but they are nowhere near empagliflozin as regards prevention of cardiovascular death. A new multinational gliflozin known as utrogliflozin has been launched in United States of America. It is only cardio safe. It is not cardioprotective. It's good for prevention of heart failure, but it is not cardioprotective from 3-point MACE. It is cardio safe. So these are the differences between DPP-4 inhibitor on one side and gliflozins on other side as regards their cardiovascular outcome studies. And then I talk to you about relative differences between empagliflozin trial, that is EMPA-REG trial, versus canagliflozin trial and dapagliflozin trial. Of course, canagliflozin trial and dapagliflozin trial included some patients who did not have cardiovascular disease, but who had only the risk factors for cardiovascular disease, whereas empagliflozin trial, all the 100% patients included were those who had a cardiovascular disease. Utrogliflozin also included 100% patients who had cardiovascular disease. So it is, so in general, what you can message here is you go by the trial, you go by the findings and treat it as a molecule effect and not a class effect. So based on clinical trial and some mechanistic studies, what are the properties of gliflozins in general and empagliflozin in particular, which lead to all these cardiovascular benefits, renal benefits? It has benefits on the pump, that means heart muscle. It has benefits on the filter, that means the kidneys. It protects the kidneys, it protects the heart, and it has the benefits on the pipe, that means the blood vessels. And of course, all these are besides significant reduction of HbA1c. Significant reduction of systolic blood pressure, reducing artificial arterial stiffness, systemic nervous system activity reduced, so it doesn't let the pulse rate go up, so oxygen consumption is reduced, weight is reduced, visceral adiposity is reduced, insulin resistance is thus indirectly reduced, oxidative stress is reduced, of course blood glucose is reduced. LDL cholesterol increase is not dangerous because it's not low, small dense LDL particles which are reduced, but triglyceride reduction and HDL increase is beneficial. Uric acid is emerging as an important risk factor for cardiovascular disease. Empagliflozin is known to reduce uric acid, it's known to reduce albuminuria, renal protection, and if you protect the kidneys, you protect the cardiovascular system. And that's how, through the multiple effects, the empagliflozin, besides controlling blood glucose, is cardioprotective. It protects from hospitalization of heart failure, and it protects from sudden cardiovascular death. EMPA-REG outcome study, as I showed you, the difference between EMPA-REG outcome study, Canvas program, and DECLARE trial, I have already told you, is the basic difference is the cardiovascular death. 38% relative risk reduction with EMPA-REG trial, whereas 13% relative risk reduction in Canvas trial, and hardly any relative risk reduction for cardiovascular death in DECLARE trial, which was with dapagliflozin. Of course, on the overall composite 3-point MACE and overall ability to reduce hospitalization of heart failure, all these three gliflozins were equally effective, and so they are as regards kidney outcomes. All of them are very protective. Canvas came out with a specific renal outcome trials. In addition, canagliflozin came out with specific renal trial in addition to Canvas trial, proved to be very effective. Similarly, dapagliflozin has come. Empagliflozin trial is about to be over now, but the initial results are as good. And if you look at the secondary endpoints in the EMPA-REG trial, they are pointing towards the same. So equally good in 3-point MACE, equally good renoprotective effect, equally good heart failure protection, hospitalization of heart failure significantly reduced. But on the top of that, what makes the empagliflozin stand out is a significant 38% relative risk reduction from cardiovascular death. So all this data has changed the guidelines. I talked about it, how they have made paradigm shift to the guidelines. It is no more start with metformin, add sulfonylureas. If it is not working, then add gliflozin, then add dapagliflozin. If metformin is not necessarily now considered as the drug of first choice, if your patient, when you see him for the first time, if he is diabetic and if he requires anti-diabetic drugs to reduce his HbA1c, and if he already has the cardiovascular disease, atherosclerotic cardiovascular disease, you need not start with metformin. It is not necessary that you must start with metformin, wait for metformin to fail. What ADA subtly and indirectly says that if you get such patient, you can indirectly consider empagliflozin as a drug of first choice, or at least even though your HbA1c is not very high, even though in the normal circumstances you would have started with metformin and added gliflozin later on. In such circumstances, already with atherosclerotic cardiovascular disease, you need not wait for metformin to fail. Start metformin and SGLT2 inhibitors together. That's what ADA is saying. European Association of Cardiologists has, for the first time, out and out said in 2019 onwards that in atherosclerotic diabetic patients with atherosclerotic cardiovascular disease, you start your treatment with SGLT2 inhibitors. If it is advanced, you start with empagliflozin. If it's only risk factor, you may consider other things. You start your treatment with a SGLT2 inhibitor and then add metformin as second stage. So already the shift has occurred. ACC AHA guidelines now are more or less saying what ADA is saying, that it need not be that every patient you would start with metformin. So this is all about SGLT2 inhibitors and paradigm shift in management of type 2 diabetes. Dr. Vijay Shah would of course talk about paradigm shift in management of heart failure and how cardiologists are using empagliflozin primarily, and other gliflozins also, primarily as a heart failure drug, and how nephrologists are using empagliflozin and other gliflozins primarily as a renoprotective drug. But one caution here, if you want to use empagliflozin as a or for all that matter, any gliflozin for a renoprotective drug in a patient with advanced renal impairment, say for example, EGFR of 25, you will get a good renoprotection, but you would not get a good anti-diabetic action. So there you would be using it as a renoprotective drug and not an anti-diabetic drug, because to give you a good HbA1c reduction, renal function should be good. That's all. Viti, I hand it over
Thank
to
you.
you now.
Excellent. Excellent, Dr. Talwalkar, for this review. You made my job very easy. I think 3/4 of my job was covered. I am left with 1/4. But I am very keen to interact with you and ask you many questions on this diabetic portion. So first of all, let me now go to my perspective. If you can stop sharing your slides, maybe. Yeah, the tech team may, yeah. So, yeah, yeah. So, am I heard and seen properly?
Yes.
No,
Yeah.
sir.
Can you see my slides?
No, the slides can't be seen. Please share it.
Slides can't be seen. So,
Share screen. Go to share screen.
yeah. Just a second. Why? Because, uh, okay, share screen and
Select the slide.
this one, and this one. So now can you see?
Yes, yes.
Yeah, excellent. So, friends, after that very quick and fast and exhaustive review of SGLT2 inhibitors in diabetes, their role and how it evolved, let me come to my part of it and let you know that in 2020, the SGLT2 inhibitors also are a pure cardiac drug. When I say that are also a pure cardiac drug, is because that means that even in those patients who don't have diabetes, we have indications, approved indications for that. So now, why is it and how is it? Let me go through this history and you will be convinced that yes, it is also a cardiac molecule, not only a diabetic molecule or cardiodiabetic molecule, but also a pure cardiac molecule. So as we all know, we heard from Dr. Talwalkar about all the atherosclerotic cardiovascular diseases also. So MI, stroke and cardiovascular death. But one thing which is additional and which we have learned from this diabetic population over period of years, if you escape ASCVD, you land in heart failure. Or else if you have premature ASCVD, you land in premature heart failure. So, and that we long back, we learned from the Framingham heart study that over period of 30 years in diabetic population, it was cardiac failure which was the major death. If you see here, especially in women, in the center, cardiac failure, you see the most maximum deaths in blue and red, that is men and women, was with cardiac failure. So besides ASCVD, the biggest elephant in the room today is heart failure. And why is it so? Because of the aging population. Our population is aging with better antihypertensive, better diabetic management, and so on. So we have more of heart failure. Therefore, with this, we started concentrating on heart failure, especially in diabetic population. Now, these are various heart failure outcome trials of all these drugs. We showed that heart failure is also a major cause of death in diabetic population, whether it was a well-controlled diabetes or whether it was not so well or less intensive control or intensive control. In both the arms, the heart failure was equal almost. So, now, as he was saying that with all the anti-diabetic drugs, one drug which could reduce the heart failure incidence, none of the other drugs could reduce. In fact, drugs like TZD, that is pioglitazone and rosiglitazone, especially rosiglitazone, as we all know, increase the incidence of heart failure and cardiovascular death. Rest of all of them, whether it is sulfonylureas, insulin, or GLP-1 RAs or DPP-4 inhibitors, they all were neutral. Some of them molecule-wise were slightly bad than the others, but none of them was significantly good, except SGLT2. And that was also courtesy EMPA-REG outcome and courtesy the US FDA regulation that all the newer anti-diabetic drugs from 2008 will have CVOT outcomes. To the extent, if you see in this, whatever slide which he showed and discussed and really explained it nicely, that in this 3-point maze, the fourth point, heart failure, was not included because nobody expected that. They said CVOT outcomes, you want safety. Okay, fine. Here is it. MI, stroke and death, cardiovascular death. So that's it. So they did count heart failure into consideration. And then as a secondary outcome, as you see here, hospitalization for heart failure decreased. That's the time when their eyes opened up that we have this classical benefit on all these 3 points, especially cardiovascular death, which is a hard endpoint. None of the other SGLT2 inhibitors showed this, but EMPA showed that in this high-risk population, both with established ASCVD and with high-risk features of cardiovascular factors, that it reduces cardiovascular death as a hard endpoint, plus hospitalization for heart failure. Now, this was a secondary outcome. So this was a sort of bonus which they got. So then to prove this, that this is also one of the primary benefits of this drug, they had to do a separate trial. So that separate trial was then designed. Now, as he showed all this and explained this, that HHF, which we call in short, is universal for all SGLT2 inhibitors, right? So it is a class effect. But in EMPA, we have CV death. So this is a particular molecule which gives you benefit, and I think we should all prefer this molecule, especially for all established ASCVD patients. But what about heart failure? As I was saying, that one has to prove that it has got a benefit primarily in this. So therefore, this trial was designed, which is known as Emperor Heart Failure Studies. Now, as we all know, This is, of course, the trial which was recently published in August at the ESC meeting, that cardiovascular and renal outcomes. Please remember that in heart failure, both of them go together, also in ASCVD, but more so in heart failure. If you have worsening heart failure, it is worsening renal outcomes. Worsening renal outcomes leads to worsening heart failure. So it's sort of a coco game which they play together. So always when we treat heart failure, we have to take care of the kidneys. We have to take care, and therefore the cardiologist also started learning more of nephrology. Only time when we used to do this practice was when we were giving RAS inhibitors, ACE inhibitors or ARBs and checking the creatinine and potassium levels in those patients for treatment of hypertension. But now we know that with these drugs, even renal outcomes have to be monitored. So both are beneficial, and this is how the trial was designed. I am not going to go into details, but sufficient to say that you all know that heart failure are two types basically, one with reduced ejection fraction and the other with preserved ejection fraction. Now, all these reduced and preserved ejection fraction were never taught in our college days. It is only in the last decade that we found out that at times some of the trials showed benefit and some of them did not show, that this was taken into consideration. Therefore, we all know now that ACE, ARB, ARNIs, which are good at reduced ejection fraction, have not shown to be, have not proven to be equally good in preserved ejection fraction. So we know that these are a different ball game together. So a trial first was started with reduced ejection fraction, where it is easy to show benefits. In preserved, it is difficult, but nevertheless, with so much of promise in these SGLT2 inhibitors, that most of these SGLT2 inhibitors now have a trial on preserved ejection fraction also. So Emperor preserved is there also, and DAPA also has a preserved ejection fraction, the deliver trial which they are conducting. So Emperor reduced ejection fraction less than 40% were considered, with of course all other signs of heart failure like anti-proBNP and so on were taken into consideration. And it was a multi-centric trial. All over the world patients were taken, including India, and they found that the benefit was much more. So this was the trial. Primary endpoint, cardiovascular death and heart failure hospitalization. Primary endpoint. Once you prove as a primary endpoint, then it is a solid indication to use this drug in that. Now, what did they do in this trial? They had two groups of patients, one diabetic, the other non-diabetic. So they had two arms. So somebody thought of it that if this drug is so good, why not try the non-diabetic population? Now, what is the hypothesis in non-diabetic population? We all heard from Dr. Talwalkar that this drug throws away urinary glucose and therefore the blood sugars come down, and the other various weight reduction and visceral fat reduction and so on. So if this is acting like this, then how come in non-diabetic population it will act? So please remember that our renal threshold is 180 for glucose. Over 180, all the glucose is thrown out, right? But what happens that if this EMPA or this SGLT2 inhibitors, they decrease the threshold to 120. So what happens is that if the sugar is above 120, it is thrown out, even if the patient is non-diabetic. That was the hypothesis which led them to say, okay, if this drug is also having this kind of action, let us have a non-diabetic population. So this was it, and fortunately to their surprise, they found equal benefits in non-diabetic population. Therefore, I say that today this drug is also a pure cardiac molecule, not only for diabetics, but for non-diabetics in heart failure. And with DAPA CKD proving in non-diabetic population for prevention of renal worsening, today it is also a cardiorenal molecule. So this is it. Now we see here the other secondary endpoints of slope in decline of eGFR. This was, so 7,000 and odd more studies were enrolled and age more than 18 years. So please remember One of the exclusion criteria was acute heart failure. We don't give this drug in acute heart failure during the hospitalization phase. So what we do is that because during the hospitalization phase, the renal parameters are fluctuating. You know, one day the creatinine gradually grows up as you give more diuresis, the hypokalemia occurs, and there are a lot of electrolyte imbalances. There is dehydration, and as you heard from Dr. Talwalkar, that dehydration is one state where your SGLT2 inhibitors should not be given. So all those patients were excluded in this, and a select of chronic heart failure patients with history of heart failure having, those were the patients who are included. This is the exclusion, as I showed you: acute coronary syndrome, stroke or TIA, and cardiomyopathy, severe valvular heart disease. Acute decompensated heart failure was also an exclusion criteria. And of course, some devices which were implanted in within 3 months. Now, Asian population was 18%. And I'll tell you an interesting factor in this, which we would like comment from Dr. Talwalkar also regarding that. Now, in this trial, especially in the Emperor reduced trial, the EGFR, which normally for diabetic population, their product information mentions that not to use less than 45. So 60 is the official, 45 is what was tried out in the trial. But here in this trial, the EGFR was as less as 20. Okay, so you can use it in those CKD patients with EGFR of 20 also. And these were the principal findings, that there was reduction in all 3-point MACE, Emperor reduced time to CV death or hospitalization for heart failure, both first and repeat hospitalization. There was a significant, and the trial was prematurely stopped. You know, before the completion of the trial, the advantage seen was so much significant that they said there is no point. It is unethical to go further with the trial and have more deaths in the placebo arm. So the trial was stopped. And these were the significant reduction in hospitalization for heart failure and composite renal endpoint. So as I was saying, that deterioration in renal function gives rise to again repeat hospitalization or worsening of heart failure. Worsening of heart failure gives rise to less perfusion of the kidneys and more worsening of the kidneys. So all this is a sort of a merry-go-round going on, and vicious cycle is set in, and that breaks by this. And as he said, the best thing is that within a month you get the benefits of this. So we have reduced cardiac preload, shift to ketone metabolism. Now we have a theory that we have got SGLT2 inhibitors even in the heart. So that also is a theory which we are looking at. Adaptive cellular reprogramming, inhibition. So there are various hypotheses of how this drug is acting. Of course, reduced cardiac fibrosis, which is a long-term benefit which you will get when you use these drugs. As we see that in the Framingham study, it took 20-30 years for diabetic people to have heart failure because of the slow onset of cardiac fibrosis and the deterioration in LV function. So that long-term benefit also you will get. Now the other beauty of this drug, which you should understand, that why this drug also gives you extra diuresis when you add this to a regular diuretic which we use in heart failure. Maybe it is furosemide or torsemide or chlorthalidone or hydrochlorothiazide. So whenever you use this, in addition to that diuretic benefit, we get benefit when you add SGLT2 inhibitors. Why? Because those diuretics reduce the volume load in the vascular, and SGLT2 reduce the volume from the interstitial edema. So the interstitial edema decreases. So these are both additional. In fact, when in heart failure, where the blood pressures are very low, 90, 100 and so on, we reduce the dose of the regular diuretics and then add SGLT2 inhibitors just to see that the patient doesn't go in hypotension because of excessive diuresis. and sometimes they can lead to worsening of renal function initially. So that's why we have to adjust the dose when we add these drugs to treatment of heart failure. And over period of time, we see that the heart failure is not only controlled, but the renal functions also improve. So overall, it's a cardiorenal benefit. So here, this is a very important slide, and I would like to emphasize on this slide and just elaborate on what does it mean. So there are two things. You prevent heart failure and you treat heart failure. Let us go to treatment. What is the standard treatment, as we call four pillars of heart failure treatment today, which was said till this emperor reduced trial came in. These were ACE, ARB or ARNI, beta blockers, MRA. If beta blockers cannot be given, you give ivabradine. So these were the four pillars. Then came the fifth pillar, which is SGLT2 inhibitors. And now the sixth pillar is the CRT or ICD, that is the devices. So these are the therapies. So as a standard therapy of chronic heart failure, SGLT2 inhibitors, especially DAPA trial came in first 1 month before the emperor reduced, and now the EMPA trial has come in. So you have all these drugs to prevent heart failure, good control of diabetes, good control of hypertension. You give statins, and if there are ASCVD patients, you give antiplatelet agents and so on. Weight loss also is one, and so on. But in therapy, we have now added SGLT. So now the next question which you will ask me is, which one to give first and in what dosage to give. Now, please remember, in acute heart failure, we give diuretics and control the heart failure first. Get the oxygen saturation normal, get the pedal edema out, make the patient breath ambulatory till that time, right? You give diuretics. If he is hypertensive, you give either ACE or ARB. And then once the patient is stabilized, you can shift to ARNI and so on. MRAs are added together right from beginning. If the potassium is low, you can add. If not, and if the potassium is high, you wait for some time till the kidney function improves and then add MRA. So basically, depending upon the patient profile, the profile of the patient, you will add the drug. Whether to add, if there is CKD and the potassium is going high with RAS inhibitors, then you will wait for some time. Then I would give him diuretics, I will give him beta blockers, I'll add him an SGLT2 inhibitor early in the game. But if he can tolerate ACE-ARB, right, I would add that first. In the trial, SGLT2 inhibitors was given over and above all the standard therapy which we are elaborating. Whether it was ACE-ARB or whether it was ARNI, it was beta blocker, it was MRA, all these drugs were given, and over and above SGLT2 was added, and they showed significant benefit in spite of your best medical treatment. That was the solid proof that makes us today very much confident in adding SGLT2 inhibitors to all our heart failure patients. We added. Now the beauty of SGLT2 inhibitors, it is single dose. You don't have dosage like you have in ACE-ARB. You start from 2.5, give 5, then 10 and so on, or start from 50 or 100 and then 200. It is straight single dose of 10 milligram, and it doesn't cause any hypoglycemia for the patient. Please remember, hypoglycemia will be there if you have already a patient of diabetes on oral hypoglycemic agents, especially sulfonylureas, or if he has insulin drugs which cause hypoglycemia. But generally, it is not when you give with all the other agents like DPP4 inhibitors and so on. So basically, as I was saying, that you have to decide when to add on the therapy, how to add, and titrate the dosage accordingly. So the emperor reduced. Now we will have possibly in a year or two the emperor preserved also. Let me go quickly all through this slide. These are all repetition of whatever I was saying. And DAPA HF. So these are the various editorials from this slide. Of course, now I have to tell you one thing. You see, these are ESC and AHA-ACC guidelines. Now, Dr. Talwalkar was also mentioning about the GLP-1RA, right? These are also excellent molecules for ASCVD, especially semaglutide and liraglutide trials have shown that they reduce the incidence of MI and death. Confirmed ASCVD patients. The only problem with this, as on today, it is only available as injectable form and is very expensive. Both these criteria are not acceptable to majority of our patients. Now, we would like to give this molecule, especially high-risk patient, post-CABG, post-plasty, recurrent ACS, recurrent MI coming. What would you do? How many? You can give statins, antiplatelet, this, that, everything. But this molecule for diabetic patients has proven added above all the standard line of treatment. It has given reduction. We would like to, but as I said, in practice, hardly 1 in 100 accepts the cost and the injectable form. But alternative to that is EMPA, because EMPA also in ASCVD patients has shown to be beneficial, unlike DAPA and CANA. So that is one molecule which we have started adding right since the time the EMPA outcome was declared, and this molecule was introduced in the Indian market. Especially if the patient has heart failure, no question, SGLT2 first drug of choice. If the patient has cardiorenal heart failure, no question, it is first drug of choice. So that would be it. In fact, if the patient has been diagnosed with diabetes and is an established CVD patient, that we forget about metformin and start SGLT2 inhibitors in these patients. So thank you very much. And if there are any questions, comments, and we will take up during this discussion.
Okay, sir.
So I stop sharing and we can go on the gallery view so that we can see Dr. Talwalkar also.
There is one question for you, sir, Dr. Vijay, to BT.
Yeah.
The question is, in case of worsening heart failure events or any multiple CV risk factors, which SGLT2 inhibitor is the drug of choice?
Pardon, in case of?
In case of worsening of heart failure events or any multiple CV risk factors, which SGLT2 inhibitor is the drug of choice, according to your experience?
No, of course, in worsening heart failure with lot of established CV risk factors, there is no question. It is EMPA, which is the drug of choice. You can give DAPA also. That is not if patient is for heart failure. But if it's a combination of ASCVD risk factors and heart failure, I would prefer EMPA.
Yeah. Okay. There is a question for Dr. Pradeep. The question is, which SGLT2 inhibitor acts better in non-diabetic patients with hypertensive kidney disease?
You're talking about kidney protection with SGLT2 inhibitors. As we have shown the data, all of them are equal. But as far as DAPA and CANA are concerned, there's specific specific trials where kidney protection was the primary endpoint are completed. As far as EMPA is concerned, the indications are it is equal to them, but their kidney endpoints as a primary endpoints, that particular trial, the findings are not yet out, but all the early indications as well as the empiric trials in which kidney points were secondary endpoints are showing towards the same thing. And I would say from kidney protection point of view, even though the designs are slightly different, all of them are same. But there is one difference between the three. EMPA kidney trial is being done in those patients with even eGFR of 20. CANA was done with 30. DAPA was done with 25. And now with EMPA, you are going even to more advanced renal function deterioration. So you will have more experience in treating very advanced renal failure patients with empagliflozin as compared to CANA or DAPA. So though the findings will be available after some times, though EMPA is slightly late in this particular aspect, when the findings come, it will be beneficial because it will give us the experience of handling the most advanced renal failure patients, which were not included in CANA and DAPA trial.
Okay.
And secondly, this hypothesis was also tested in the Emperor reduced trial where the eGFR cutoff was 20. So they
Correct.
took all those patients as low as 20, all those heart failure patients as low as 20, and they showed benefit in the renal outcomes. So as a secondary endpoint, it was tested, and now as a primary endpoint, the results of the CKD trial will show us that.
Okay, thank you, Dr. Pradeep. There is no more questions. So, any closing remarks for Dr. Pradeep
No,
in
what I would,
perspective?
I had a question for Dr. Talwalkar.
Yes, sir. Yeah,
This
definitely,
is
definitely,
just
sir.
one question since he's there. I thought,
Hmm.
see, many years back, these glitazones were used quite commonly in India, pioglitazone. Now, of course, only pio is available, and the indication is to use, reserve it only for specific indications and to rule out reduced ejection fraction before you use it. My question is that a combination of EMPA and PIO, if given, to reduce the dose of SUs or to minimize the use of SUs so that there is less hypoglycemia. Would that be a complementary action, or would that be a good combination, or that is not practical?
You see, the action will be complementary as regards their anti-hyperglycemic actions because totally different mechanisms of action. Action will be complementary as regards their weight action. One will increase the weight, other will neutralize the bad effect of increased weight. The action will be also complementary as regards edema because one would act like a diuretic. And unless the patient has an advanced heart failure, you can always use it. And many times some of us are using it because, in a day-to-day practice, if you're working only for a diabetic patient, you get a lot of patients where you do anything and everything, the blood sugar is not under control. So sometimes you have to use all these juggleries, and I have used it in patients together, and it works.
Very good, excellent. So that's what I was thinking, because I thought that yes, that fellow gives you edema and weight gain, and this fellow reduces it. So maybe it is like, amlodipine and ACE inhibitors that we combine together so that the edema of amlodipine is taken care by ACE inhibitors and so on. So that's a very good information that you are given from
Yes.
practical experience.
Yeah.
I would right. So now we are waiting for that preserved ejection fraction. One that proves in both in diabetic and non-diabetic. I tell you that this drug will, the usage of these drugs in both diabetic and non-diabetic population will exponentially increase because most of our diabetic patients, if you look for diastolic function, they will have diastolic dysfunction and they will have breathlessness. So many of them would have. In fact, we are not evaluating them aggressively for the simple reason is that we don't have a specific answer as on today, except when they go in acute heart failure, when you use diuretics and other drugs. But otherwise, we don't have a specific drug for that, and therefore we are not evaluating them. But once this drug shows a promise in that heart failure also, then of course people will start looking for the diastolic function also on echo and other parameters and start using this molecule also in that indication.
Okay.
Viti, I have one question for you.
Yeah, please go ahead. I would love it.
In a day-to-day practice, I see a lot of elderly diabetic patients who are tired, who are weak. They say, I have a lack of stamina, etc., etc. Till 2 years back or 1 year back, I was not thinking about heart failure. But with this explosion of knowledge about EMPA-REG and all the DAPA and CANA and heart and diabetes, cardio-diabetology, now I am convinced there are large number of diabetic patients, elderly, who are in cardiac failure and who are missed in day-to-day practice. Because they have a little bit of high creatinine, they are a little bit anemic, they are elderly, they have hypertension, सो ये लेबल लगाया जाता है किडनी फेलियर से वीकनेस है इससे वीकनेस है उससे वीकनेस है बट nobody or very few people including cardiologists are putting that label but I see lot of them sometimes I refer to cardiologist I don't get proper answer then I ring and say don't you think it is a heart failure and then they are at
Exactly. So, well, you said it correctly. See, as you said, because of this, 10 years back, tell me, did we ever think of preserved and reduced, as I was saying? So it was only the charm trial, the charm preserved trial actually was separately designed, and then we realized that preserved and reduced, when it did not show any benefit, we realized that these are two different things. And unfortunately, what has happened is that today, all those patients which you are saying, the diastolic function generally is not looked after. The best way in echocardiography to look for diastolic function is not the Doppler indices which regularly people report, but it is the GLA strain, LV strain pattern which is important, and a strain pattern of less than 15 is the indicator of diastolic dysfunction. Unfortunately, the machines are not so much upgraded, and whether you report that or you don't report that, it doesn't make a damn difference. The cost is the same to the patient. So people say, what difference does it make? Chala lo abhi I say E to E ratio, E dash ratio, or type 1 or type 2 diastolic dysfunction. The other thing is looking at pro BNP levels also. You will see marginally raised pro BNP level. Now, the other thing is that many a times your diastolic function may be normal at rest on echo, but abnormal as soon as they walk 6 steps or a 6-minute walk test. We don't do that in practice. If you ask them, if you're not getting any diastolic dysfunction at rest, please look after any 3 or 6-minute walk test, as we call. If you do that, they will find diastolic dysfunction. The only problem is these frail patients, I am scared. With weight of 40, 38, 42, to start an SGLT2 inhibitor in a diabetic patient, I'm a bit scared. What is your viewpoint?
Yes, if you want to start, of course, you will have to stabilize their blood pressure. You can try to reduce diuretics if they are taking diuretics. You have to train them about how to get up in 3 steps. They don't suddenly get up and have a postural hypotension, fall and develop a fracture. That's what happens with Canna. So after that, and of course, a small dose.
Right.
With all this, then you can use it.
So, yeah, so as I said, and I'll tell you that even if you don't get these evidences of diastolic dysfunction or heart failure, as we call, if you give them this SGLT2 inhibitors, you will see benefit in them. Many of these patients, when they don't improve, I give them this, because unfortunately our ARNI, which is a very good drug for reduced ejection fraction, patient symptom status improves within 5 to 7 days. But in the Paragon heart failure trial, it did not show improvement in preserved ejection fraction. So we don't use it routinely, and there is hypotension with that. But then there I am giving empirically as on today, because the best evidence I say is the trial is not prematurely stopped, either because of side effect or either because of extra benefit. So that means it is still effective. Hopefully it is still effective. And initially you showed one slide in the EMPA-REG outcome, the heart failure patients were not divided into preserved and reduced. They had just taken heart failure patients. So in them, when they analyzed, they saw that preserved ejection fraction also had a benefit. So taking that into consideration, when patients are not feeling better with all the other antihypertensives and all that, I try to give them. People sometimes overuse diuretics and land into problems of increased creatinine or serum urea raised.
Okay.
So I think we should avoid that and give a trial of this. And I'll tell you that those patients with preserved ejection fraction, but having diastolic heart failure and increased pulmonary pressure, that is pulmonary hypertension, with right-sided heart failure or RV problems, also have improved with this drug. So definitely there is a role. It is just question of time that we have some trial to establish that indication and put that into guidelines.
Thank you, sir. We are out of the time actually.
Yeah,
okay.
I know that. Yeah, but
never-ending discussion actually. SGLT2 inhibitor for every.
No. I think we learn from each other.
Yes.
And
Lot of things.
When an experienced person like Dr. Talwalkar is there, it is always a real pleasure to discuss all these points.
Yes, thank you. Thank you, Dr. Shah, Dr. Pradeep, for your wonderful presentation and sharing your wonderful experiences. And on behalf of Lupin, We thank you both and take care, and we'll see in the future meetings.
Thank you, VT.
Thank
I have
you.
also learned a lot from you.
Yeah.
Thank you very much.
Yeah.
Thanks.
Thank you.
Bye bye. Stay
Bye
safe.
bye.
Good
Bye.
night.
Good night.